Our first speaker, Mark Davenport, and his talk will be surgical tips to get long native liver survival. Professor Mark Davenport was born in the northwest of England and qualified in medicine in 1981 from the University of Leeds with surgical training at Leeds, Sheffield, and Manchester before arriving finally in London in 1989. He has a postgraduate research degree awarded from the University of Leeds for experimental work on liver transplantation and organ preservation. He was appointed as a consultant pediatric surgeon at King's College Hospital in 1994. His main clinical interests are hepatobiliary diseases, such as atresia, and colloidal cyst malformation, with research supported by the Institute of Liver Studies and antenatally diagnosed surgical malformation, gastroschisis, diaphragmatic hernia, and short bowel syndrome. He runs the Biliary Atresia National Consortium Registry from England and Wales. Since 2008, he has been honored with a professorial chair in pediatric surgery from King's College, University of London. He actively promotes medical writing and has published 2 editions of 2 textbooks on general pediatric surgery and the 8th edition of the popular Robb and Smith Operative Pediatric Surgery. He has also edited an international multi-author specialist book on pediatric liver and pancreatic disease published in 2017 and written over 300 predominantly research-oriented papers and reviews, together with over 50 chapters on a variety of surgical topics. He is the current UK editor of the Journal of Pediatric Surgery. He was elected president of the British Association of Pediatric Surgeons for 2016 to 18. Dr. Davenport?
My next task really is to try and inform the masses out there about the Kasai Porta enterostomy from a surgical perspective. I think with Porta, we're probably the only surgeons actually on the faculty, so I'm really going to concentrate on trying to maximize its potential. But let's start with a few opening introductory remarks on biliary atresia itself. It can be said to start with this publication, which is the first in the English language, from John Thompson in 1892. John Thompson was a physician from Edinburgh in Scotland, and he was presented with a baby that was deeply jaundiced. And he noted the key clinical features of biliary atresia, that the baby had pale white stools and very dark urine. Sadly, that baby did die, but he had the commendable foresight to do a post-mortem. And this drawing is taken from that post-mortem, showing the very obvious cirrhosis, the cirrhotic nature of the liver. It also shows us the gallbladder, which is flat, doesn't contain any bile, but apparently connects with a normal bile duct. And he also dissected in the Porta Hepatis up here and showed 2 small cystic structures. And he took the top off one of those cysts, and that was where the bile was. This is actually a very rare type of biliary atresia, we now know. And as I say, the first one that was written for the English language. Now, at that stage, there was not a great deal of that anyone could do about this particular disease, least of all the surgeons. This is a beautiful painting by an American artist on surgery at that time. This is the late Victorian era, the late 19th century, showing how the surgery of the day was performed. As you can see, anesthesia was a little cone held in front of the face, and chloroform was dropped on it. There's the great man, Dr. Agnew, supervising it. We use the term operating theatre in the UK, and you can see from this picture why we do that. There's banked seats here, and all the observers and medical students are looking on. It is generally a theatre environment. But things do change, and surgeons did start to operate on these babies. And the first real significant one to report his findings was the acknowledged father of American pediatric surgery, William Ladd, who was working in Boston, Massachusetts. And he produced a paper in the Journal of the American Medical Association in the 1920s, describing his series of operating on atresia and similar biliary pathology. And amazingly, he recounted that he was able to restore bile flow in 6 out of 11 cases where he operated. And that stimulated surgeons around the globe in trying to emulate this performance. But it became fairly quickly clear that actually, in most cases of biliary atresia, you couldn't find anything to do a conventional anastomosis on. And the concept of the uncorrectable or non-correctable biliary atresia emerged, and all those were destined to die. And that really didn't change until the work of Mario Kasai came about. His first publication was in Japanese, as you might imagine, in 1959. He described a new operation for non-correctable biliary atresia. He was working in Sendai, the west coast of Japan. And here's a picture of him, a very eminent man, of course, and he is regarded as our founding father, our creator of all known wisdom. And he looks a little bit like Yoda, again, a master from the Star Wars series of films. And what was Kasai doing that was different from previous surgeons? Well, what he was doing was dissecting higher up in the biliary tree, above the level of the confluence of the portal veins. And even if he didn't find any bile-containing structure, he simply transected across it and proceeded with the reconstruction. Why did it work? Well, it worked because at that kind of level, embedded within the fibroinflammatory stroma, we've got microscopic biliary ductules, and you can see them represented here. And if enough of those are exposed and drain into a loop, then all being well, jaundice will recede and the liver disease itself will be abbreviated. Here is a great picture of Kasai with one of his actual patients. You can just about see the scar in her. And again, great resemblance to Yoda, including the usual unusual weapon of choice for lots of surgeons out there. So what were Kasai's actual results? Well, in retrospect, and most of this, the results I'm going to describe, actually were from his successor. And initially, the results really weren't great. Only 10% of his original series survived to 10 years. That did steadily improve over the period to about 48% in the 1970s. And this is again produced from the Sendai series up to the mid-1980s. And you can see the gradual improvement in jaundice clearance. So even Kasai had terrible results at the start. And what he was doing evolved over the period. It's an important concept, that evolution according to technique. So what were they doing perhaps at the end of this period that was different? Well, the concept emerged of that of an extended dissection within the Porta Hepatis. Kasai originally was just transecting and leaving an ovoid raw area, which he then anastomosed to a roux loop. But more and more Japanese surgeons started to go beyond that. And this is a paper taken from the 1990s, which illustrates that kind of concept. So they were opening up this is the rex part of the rex fossa, and you divided that with diathermy to open up the left side of the Porta Hepatis. Notice that they've slung the portal vein and arteries in order to get to the back of the portal vein confluence and again extend the radical nature of the section itself. And apparently in that particular series, 90% of the infants in that series cleared their jaundice. This is a similar paper with a similar principle. In this particular paper, they were putting stay sutures around the margins of the section to be resected and using that as the guide point. So the concept emerged of getting into the little nooks and crannies of all the Porta Hepatis, trying to remove all the biliary remnants. Now, most Japanese surgeons, and indeed myself, actually exteriorize the liver. I'm going to show you that in a moment, to achieve the best possible dissection of the Porta Hepatis. But there are other ways, so I just thought I'd show you this slide. This is from a surgeon at Yale in the States, and he prefers to use this where he leaves the liver in situ using a fixed retractor here in order to get it. But again, it does need experience to use it. So let's just step back a moment just to summarize what we as surgeons feel about biliary atresia. The most common classification is an anatomical classification. It's the Japanese Association of Pediatric Surgery classification. And it describes the level of obstruction. So we've got about 8%, which are referred to as type 1, where the obstruction is in the common bile ducts, the only type you'll get, whether it's bile in a gallbladder. Higher up, at the level of the common hepatic duct, we refer to that as type 2. And that probably was John Thompson's original case. But the vast majority of type 3, where no matter how high you go, you cannot actually see any visible bile ducts. These are type 3, the old uncorrectable biliary atresia. But there is a clinical classification as well. And we've worked hard to try and get the concept that not all biliary atresia is not a single disease. You can subdivide it into these various clinical variants. There's one obvious type of biliary atresia, which is different. That's the syndromic form of biliary atresia, typified by polysplenia and situs inversus. The commonest of these is what we would call biliary atresia spheric malformation syndrome, or BASM, and 5% of these have a genetic mutation. But there are other syndromic forms as well, the cat eye syndrome, and you can have other major anomalies, such as esophageal atresia associated with it in a non-random fashion. There is another variant, which we would call cystic biliary atresia, and I'm going to return to that a little bit later, because it's characterized by antenatal detection, if not diagnosis. One of the more controversial variants is that associated with CMV, specifically when the babies actually have IgM antibodies against CMV. And we've described this in a number of papers. And I'm going to, again, reiterate this a little bit later on in my talk. But the vast majority have no defining characteristic other than biliary atresia, and we would use the label isolated biliary atresia for them. So let's go through a couple of the surgical slides, if you like, just to illustrate the technique that we use at King's. Now, as I say, exteriorization of the liver, we believe, is an important way to maximize the potential for the portal dissection. Here we've divided the falciform ligament and the left triangular ligament, and we're now delivering the left lobe out of the abdomen. You've got to keep the anesthetist awake during this particular part of the operation, because you do kink the cava, so they may well need IV support. But to us, it certainly provides the best possible environment for a dissection here in the crucial bit, which is the Porta Hepatis. So this is just to reinforce that. We've got the liver out here. There's an atrophic gallbladder, very typical biliary atresia. Over here is the Rex fossa. And we're going to start dissecting in a maximally invasive kind of way. And what we're aiming to do is separate out the residual biliary structures from the vascular structures. So I've got a sling, a yellow sling around the right hepatic artery, for instance. Left hepatic artery is skeletonized over here. And at the back here is the portal vein. It's dividing into the left one here, continuous with this bit, which is the umbilical vein, and going over here towards the right-hand side. All this is to be resected. And there it is again. And what we're aiming to do is separate at the back the confluence of the portal vein by dividing these small veins which travel across the Porta Hepatis. This allows us to push the portal vein down, exposing the caudate lobe. And that's the sort of posterior limit of our kind of dissection. And then we're going into a transection phase, where we go across, removing all possible remnants of the bile ducts themselves. And you get this kind of appearance. There's a genuine anatomical plane here. The point and concept is that you cannot go any further, otherwise you would go into liver parenchyma itself, and that's not good. Well, no one's advocating coring out the liver tissue itself. It doesn't seem to be a stable plane of dissection, but this certainly is. And it's a wide dissection as well. So on the right-hand side here, is actually the bifurcation of the right vascular pedicle into what we now know is called Rouvier's fossa. And on the left here, this is a Rex fossa, which has been opened as well on the left side. So it's a wide dissection as well. And if I could schematically illustrate that here, all of that is going to be incorporated into the roux loop. So it's a dissection from Rouvier to Rex. And this is the kind of standard roux loop that we would do. No real differences here, 40 centimeter roux loop, and now doing a staple jejunal anastomosis using very fine sutures to complete the actual anastomosis itself. So post-operatively, we've all got our particular favorites here, and obviously this changes to whichever hospital you're operating on, but this is our current regimen at King's. Antibiotics fairly non-contentious, and we continue those for a month. We use ursodeoxycholic acid. We've been using that for about 10 years. We're great believers in high-dose prednisolone, starting at 5 milligrams per kilogram per day, and we now treat, if we can recognize these infants to be CMV positive, with valganciclovir. So let's just say a few words on steroids and how we came to what we do now. We started our interest in the inflammatory nature of biliary atresia a long time ago now, almost 20 years ago. This is looking at it's an immunohistochemical study on liver and bile duct remnants. We were looking at the elements that constitute acute inflammation. And what we found was in 50% of the series, there was abnormal expression of class 2 antigen, HLA-DR, on Kupffer cells and macrophages. It shouldn't be like that. There was also abnormal expression of the cellular adhesion molecules, ICAM and VCAM, on bile ducts and sinusoidal endothelium. Again, about 50% of them showed this, so not all by any means. And in a third of this series, there was a marked small cell infiltrates consisting of CD4 positive T cells and CD56 positive NK cells. So this is abnormal. They were doing something, they were activated, they were proliferating. In a later paper, we also published on what was happening in the circulation after the Kasai as well, by measuring cytokines, cellular adhesion molecules, up to about 6 months after the Kasai operation. And we showed there was a non-polarized response, neither Th1 nor Th2. But in certain cytokines, there was a dramatic increase in levels, IL-2, TNF, IL-18. And just to illustrate that concept, I've reproduced 2 of the graphs here. So this is soluble ICAM. And there's an increase in levels after the Kasai, as you can see here. What you can also appreciate is in those children that actually were clearing their jaundice, their ICAM was coming down. Similar for the TNF, notice the change to a logarithmic axis to get the wide variation in TNF. But again, dramatic rises in TNF in the post-operative phase. And again, separation of those infants that actually were starting to do well. Okay, so we've established an inflammatory basis for some of these infants. Could you do something about it? Well, we did. We described the first randomized double-blind placebo-controlled trial, reported its effects in 2007. Not much clinical effect, it has to be said, but there were definitely biochemical differences between steroid and placebo. And we then moved on in retrospect, because it was a low dose regimen that we'd chosen, to move on to a high dose regimen. And with that, we also abandoned the placebo-controlled nature of it into an open label study and reported that in 2013. At that same time, George and colleagues from the States reported the START trial, which also was a high dose steroid trial. And what I like to do here is a head-to-head comparison of our results versus the results of the START trial, because importantly, they came to different conclusions. So the START trial, multi-center, as I've said, what was also obvious from it was these infants were fairly old, so the mean age was 69 days. And steroids really don't have a great deal of effect on the aging liver. Not surprisingly, it's fibrosis, it's cirrhotic. It really doesn't have the great effect that you might see in an otherwise younger liver. And using a similar sort of index of clearance in the all-comers arm, in the steroid group, 59% cleared the jaundice and 49% cleared in the placebo arm. A difference of 10%, but not statistically significant. They then looked at a subset of less than 70 days, obviously reducing the numbers by half. And in that steroid arm, 72%, which is quite an amazing figure, cleared their jaundice, and 57% cleared it in the placebo arm. A difference, but again, not statistically significant. So they concluded there was no effect. This is our experience. All of ours in this analysis were less than 70 days. And we had a lot more. We had 153 that we could use for comparison. In our steroid arm, 66% cleared their jaundice. In the control arm, 52% cleared their jaundice. And because of our bigger numbers, the difference did breach statistical significance. But if you look at the numbers, they're the same. The difference is the same, 14 to 15%. Okay, so the other thing now I'd like to sort of finish with is our national results, just to give you an illustration of the kind of things I've been talking about. Our centralisation policy happened in 1999 for England and Wales. And with that, we've published a series of papers on our national results. So what I'm going to present to you is not actually published thus far, but it's the up-to-date results to 2019. And in that series, we've got 867 babies. Let's look at what happened to them. Half of them have come from Kings. Well, firstly, we look at the age at Kasai, and the age at Kasai in this particular analysis overall was 51 days. Currently, it's now dropped below that to 48 days. So we're improving in terms of getting these babies to surgery. We keep a very strict biliary atresia registry, and these are the kind of bits of data that we keep in it. I've mentioned the time to Kasai as a key outcome measure, and I'm now going to consider the other two outcome measures. Firstly, and this is clearly of great importance, not only to the surgeon, but to the unit from which these babies emerge, and that's the clearance of jaundice rate. And as you can see, I'm using an actual level which is normal, less than 20 micromoles per litre, about less than 1.5 milligrams per DL. We achieved clearance of jaundice overall in 60.8% of this group. And when we split it up into eras, or 5-year eras, then there is a difference over the period, from 54% at the beginning up to now 67%. So this is a national clearance rate of 67%. How does that compare? Well, I've simply chosen some national statistics here to compare. So a couple from Taiwan and Japan, and as you can see, it's very comparable with those. But look at the European statistics on clearance of jaundice, highly variable, and the only one that really is comparable is from the cold Nordic countries of Sweden, Finland, and Norway itself. The others really are lower, degrees lower than our own figures. The next sort of key measure of outcomes are looking at the native liver survival. And this is our native liver survival for the whole period. And it's 51% at 5 years, falling to 47% at 10 years. You can see, as with most Kasai series, the rapid early fall off in the first 2 years, and then a sort of plateau phase. But again, it's always on a downward trend. Okay, how does that compare? Well, if we look at Japan, again, very comparable. Not so much difference in terms of the European figures, although France is a bit of an outlier here. And with the North American series, although, again, not strict, only Canada is the national outcome, and their 10-year native liver survival is 26%. We've got no national data from the States itself, but that's what I've produced there is the BARC data, the forerunner for children, and that was 46%. Overall survival is about, there we go, there's our things, 92% at 5 years, 90% at 10 years. So it still represents, you know, a mortality, a potential mortality of about 10% for these infants, and we should never forget that. How does that compare? Actually very similar in Japan and also in most European countries and indeed the USA. So I'm not presenting anything revolutionary at the moment because I think most of these are about marginal gains. I think there are, the Kasai portoenterostomy, you have to maximize its results. And I think the liver out position is the better way of doing an extended dissection. I don't think there is a role for laparoscopy other than perhaps in diagnosis. And I'm going to go into a little bit more detail over that a bit later. I have presented our experience with the anti-inflammatory steroids, and I will present our experience with antivirals ganciclovir and valganciclovir a little bit later on as well. So know your results, follow up your patients, and be critical. And I'll hand myself back to the moderator, and stop sharing my screen now.
Thank you very much, Dr. Davenport, for your great talk. You have placed some fuel for the next debate. But I will try to concentrate with some surgical aspect. I think we have a question from the audience. We start with this. These come from Dr. Martinez from Peru. This one is about the biliary atresia, syndromic biliary atresia. How is the post-care managed, and the decision to transplant has any particular thing that needs to be thought? Compare this with the standard biliary atresia. This is one thing.
Can you still hear me, Carlos?
Yeah.
My screen is frozen. Can you still hear me?
Yeah, I'm hearing you perfectly well, Mark.
Okay, as I say, my screen is frozen. I'm going to try and do something with that in a moment. But in terms of the syndromic ones and transplantation itself, clearly some of those, because of their vascular anomalies, do present significant challenges to the transplant surgeons, no question. Otherwise, their preparation for transplant is not that much different than those with isolated biliary atresias.
Okay. So the second question of the same person is about the CMV positive biliary atresia. To start treatment, regular treatment with the valganciclovir, you use the viral load, or you just with the IgM positive?
Okay, in the next section, I'll take that in a little bit more detail. So initially, all of these were defined by having IgM positivity. We were then doing viral loads on them. Okay. And when we first started treating them, we just treated those that were CMV positive. As time went on, we then used the actual knowledge of the viral counts, the quantitative viral estimation, in order to select out those we think would actually be treated. So those with very low levels, we didn't treat.
Okay. Oh, yeah.
So we do use viral loads now in determining whether they're going to be treated or not.
Perfect. Okay, and the sense of the time, I will do some question coming from Portugal. Do you use it from Dr. Jorge Luis Santos? Do you use URSO even in patients that you don't see bile flow after the portoenterostomy? Yeah,
so URSO is prescribed from day one.
Okay.
So it's clearly it has no real effect on whether you restore bile flow or not. What we believe, there may be advantages in promoting bile flow once bile flow has been restored, but we don't wait to start URSO. We start that early.
Okay. We have a Dr. Becerra's question here. As you are operating on youngers, as you are operating on younger babies, do you see any visible changes in the extrahepatic bile ducts, perhaps incomplete obstruction or swollen ducts?
Can you repeat that one, Carlos?
No, as you are operating a younger age babies, do you see any visual changes in the extrahepatic bile ducts?
Not really, no. So
perhaps,
there's as you know, there is a spectrum of what you can see. So some of them have virtually nothing there. Now that may be a completely different subset of babies with biliary atresia. There's nothing to resect. And sometimes we use the word biliary agenesis to sort of reflect that. The sort of typical example would be, however, where there's a more atrophic sense to it. So there's not much in the way of a gallbladder. There are not much in the way of biliary remnants, but they are there. Others are more inflammatory in nature. You've got a fairly big, juicy bile duct remnant. They tend to do better as it happens. But it's very difficult to actually pigeonhole them into the younger side or the older side. We've seen both. So we've done laparotomies on young babies, and there really is not a great deal of bile duct tissue there. And conversely, older babies when there is. So there's no real rule about that.
Okay, Mark, we are running out of time. Just a short question and short answer. in this wide dissection from Rubier to Rex recess, have you ever dissected or divided the Arancio ligament just to have a better exposure? There's a Japanese.
There's a Japanese paper called from Endo that does describe that. No, is the short answer to that.
No. Well, but this is a lot more difficult. So if it's a easier thing is as good as more difficult ones, let's get with the easier thing. Yeah.
Yes, absolutely. No, I find that certainly we open up into the Rex fossa, and that's a relatively straightforward thing to do.